All right, well, good afternoon, everyone. Thank you for joining us for assessment and treatment of suicidal behaviors, best practices with adolescent and young adults, presented by Anna Lieber. My name is Jackie, and I will be your moderator for this session. Just a reminder to attendees, in order to receive your CE certificate, you must complete the post-session evaluation, which will be available within your account within 24 hours after the end of this session. On behalf of the TPN Health team, I'd like to say a big thank you to Anna and Sandstone Care. And Deborah, I will hand things over to you.
All right, thank you. So I'm Deborah Lawton. I'm a therapist and the clinical outreach manager for Sandstone Care. We are a substance use and mental health treatment provider for adolescents and young adults primarily. We provide a full continuum of care. So we have detox for adults ages 18 and up. And then we also have PHP, IOP, and a teen residential program for the adolescent and young adult population. Our programs are split into two tracks. So we have one that focuses on mental health and another that focuses on dual diagnosis. Um, that's basically it for us. I'm happy to answer any questions and provide more information if you'd like.
Great. Thank you so much, Deborah, and thank you, Sandstone, for sponsoring this presentation. And it's been great to learn more about Sandstone as we've been working together. Just a few kind of intro normal slides. Um, Obviously, everything I'm presenting today was based in research, grounded in research and from my own clinical experience, but it is not meant to be prescriptive in any way. So, no information or research can provide a better picture than the information you have about your individual clients. So, just a reminder there. As far as disclaimers, um, just an acknowledgement that there is actually a lack of research in comparison to other mental health disorders, especially research about adolescence, although it has been increasing, I would say, in the past 10 years, but it is still, we don't know a lot. So I often use my kind of read between the lines and collaborate all the data that we do have. The views expressed here are mine and mine alone. Um, and I have no financial stake in anything that we will be talking about today or recommendations that I make as far as books or treatment protocols. As we move through today, feel free to use the chat function. I much prefer a live, more interactive training. So please put in questions. If you want a question specifically to me, please use the question and answer. And I will do my best to pay attention to the chat. And Deborah or Jackie will be looking and will interrupt me. So I'd much rather that you ask a question that comes up for you and that we talk about it live in the presentation. Whenever I present on suicide, I want to always first take a few moments to acknowledge and honor, especially those who have been lost to suicide, those who are struggling with suicidal thoughts and urges, those of us who are suicide loss survivors, those who have lived experience with suicidal behaviors, and those who embrace individuals who are in pain and struggling. And most importantly, for all of us in this room, interested in this work, we have to be able to manage our own emotions to empathize with the suicidal wish. By virtue of attending this training, you are all interested in embracing this work and learning more about suicidal experiences. And my hope is that we can both learn together on best ways to work and treat these individuals and also be able to manage the pain and I would say the joy that comes from engagement with the suicidal wish. A little bit about me. I am a clinical mental health counselor. I currently live in Utah. Um, I've been working in behavioral health for 25 plus years. And in that time, I actually never wanted to focus on suicide. I actively avoided it early on in my career. And I really avoided it because it just hit too close to home. Suicidality and dying by suicide has been a part of my family's life intergenerationally, as well as a host of other psychiatric problems and trauma. So when I decided to become a therapist, I knew I did not want to work with individuals with suicide. Um, and so I actively avoided it and instead began working with individuals with substance use and then spent 7 years working with adolescents who were in state's custody and young adults who had aged out of foster care. And usually I can imagine you all sitting at home, you recognize that there may be some smiles because what happened was I realized pretty quickly that most of my clients experienced intense suicidal behaviors. Um, Many had, complex trauma and borderline personality traits. And I had to get over my fear of suicide very quickly. Um, and I realized pretty quickly that suicidality and engaging with the suicidal wish needed to be treated differently. 9 years ago, I started working at a freestanding psychiatric hospital and was the chief clinical officer. And in that role, where the majority of the patients, both inpatient and outpatient, had serious suicidal behaviors and multiple suicide attempts, that's really where I recognized I needed to do something differently with my clinical work. And I began my deep dive into training and research and learning from the experts on a different way or a better way than I was trained, which my training in my graduate program was very limited, and it really is for most graduate programs, um, of how to effectively help individuals who are struggling with suicidal thoughts and behaviors. And I hope to share with you a little bit about what I've learned and what I have found success with. Currently, I am the clinical director for Westminster University in Salt Lake City, Utah's counseling and counselor education program. So I have a lot more time to focus on suicidality, thinking about suicide, and really finding new ways to engage in the best practices. It's important that we have a common language when it comes to suicide. The term that you will hear me use the most is suicidal behavior. This encompasses really all aspects of both suicidal thinking and actions. Um, so when we think of active suicidality or as active suicidal ideation, that really is experiencing current specific suicidal thoughts and a conscious desire to engage in suicidal action or to die. Versus passive suicidal ideation is a general wish to die, but there is no plan or desire currently to engage in suicidal action. I often think of it as an indifference to accidental demise. What's important to remember when we think about suicidal ideation is that um, both active suicidal ideation and passive suicidal ideation are risk factors. And that is really because of this idea of the suicidal crisis. A suicidal crisis is a suicide attempt or incident or event, I would say, a point in time when an individual seriously considers or plans to imminently attempt to take their own life. And imminently in suicidology really is most often in the next 24 hours. Sometimes where I'm working with clients and I'm thinking in 4-hour intervals. But the suicidal crisis really is a short lasting process. For what the research really shows is that for most individuals, that suicidal crisis lasts about 10 to 15 minutes. Sometimes it can go as much as 45 to 60, although that's rare. So it really is a short, sudden onset crisis where one seriously considers ending one's life in the immediate future. And the challenge with that when it comes to the treatment and suicide prevention really is that suicidal crises are very difficult to predict. And we don't quite know yet what prompts them, and they're so individualized. Um, and we'll talk more about that when we talk about suicide risk assessment. But often we like to think that we can mitigate these suicidal crises, and yet they're so, I would say, in many cases, impossible to predict for both us and for clients. Another important consideration so that we have a common language related to suicide really is a push to shift our language in how we talk about suicide. In the past, certainly when I first started in this field, we often use commit suicide or committed suicide or a successful or unsuccessful suicide. And I think that Sally Spencer Thomas says that the litmus test for talking about suicide is to substitute the word cancer for suicide and see if the sentence still makes sense or if it has a negative connotation. For example, we wouldn't say a person committed cancer, right? Or committed um, reckless driving that resulted in a traffic fatality, right? People typically commit crimes. And so this is really related back to language when suicide was a crime in the United States and many other countries. So when we instead use died by suicide, death by suicide, that really decreases the shame and blame for both lost survivors and for individuals. Um, it also really reinforces the when you say commit suicide, that this is a selfish act or a personal choice. Similarly, when we think of successful, right, that's typically something good. And yet we often use this was a successful suicide or a failed suicide. So I've had clients where they said, well, I failed at suicide. And in my mind, that's a good thing, right? Because the person's still alive. And yet we often use this idea of failed, that they made an error. So instead, we say survived a suicide attempt, fatal suicidal behavior, or non-fatal suicide attempt. Similarly, it's really important to just use first person language. Um, People are not defined by their symptoms or their diagnosis. When we begin to say things like a person is a cutter, right? Or they're borderline, we can desensitize ourselves to the seriousness versus this person has suicidal behaviors or is experiencing suicidal thoughts. An important note, when clients often say, I had a failed suicide attempt, right? I don't correct them. I just always use a different word. Um, I don't want to increase any shame for them. Okay. When we think about in 2023, 2022, we're still compulating 2023 data, but in 2022, almost 50,000 individuals in the United States lost their lives to suicide. And in 2023, estimates are currently that has risen to over 50,000. It is currently the 11th leading cause of death and the third leading cause of death for ages 15 to 24, and the second leading cause of death for ages 25 to 34. It's important to note that 4.8% of adult Americans have thought about suicide seriously in the past year. And 54% of individuals have been affected by suicide in some way. Um, 73% of communities in the United States did not have enough mental health providers to serve the mental health needs in 2022. And of all the individuals in the US who have a mental health condition, only 46% received treatment in the past year. These statistics truly indicate that suicide is a public health crisis and causes a tremendous amount of pain and suffering. Most suicide prevention trainings that I have attended in the past have focused on the deaths by suicide and what we can do to prevent those deaths. But I actually think that there's a better way to look at suicide. I'm not minimizing the severity of this, that gives me more hope. So this statistic actually provides me a tremendous amount of hope. And I see a comment in the question and answer, and I will talk about that. So I will get to there. Thank you. Um, this is really what gives me hope. Although 12 million individuals in the US have serious thoughts of suicide, um, only 14% make a suicide attempt. And less than 1%, it's actually 0.34% die by suicide. What we can learn about individuals with lived experience that helped them improve their suicidal thinking and move away from suicide attempts and death by suicide, that gives me hope. Um, Although many people have serious thoughts of suicide, far fewer make suicide plans and fewer still report suicide attempts. And so I think this slide really provides me a tremendous amount of hope. And I hope that we can really focus on the individuals that we see in our programs and in our treatments, and that I imagine Sandstone sees really is how we can engage with them. Another way to look at this is this slide, which is pretty busy and it is posted in your handout. Um, is that there's suicide and the pathway to suicide attempts is not a linear process. There are very different ways that individuals experience suicidal behavior. Although most individuals who attempt suicide did experience suicidal thoughts and make plans prior to the attempt, many do not. This really speaks to me of the impulsivity of suicide and the unpredictability of suicide. When we look at adolescents, the statistics for adolescents are very similar to adults. Like I mentioned, it is the second leading cause of death for ages 15 to 24 across the US. That varies state by state. And it's often associated with adolescents with increased rates of depression, impulsivity, recklessness, and acting out. Specifically about adolescents, some of the concerns are really that thinking about suicide often and over longer periods of time is associated with higher rates of future suicide attempts. So, if we can really intervene and target individuals who are experiencing suicidal ideation during adolescence, we can actually hopefully maybe prevent future suicide attempts. There's also some evidence that the prevalence of the belief that suicidal behaviors are the norm may increase suicidal behaviors in adolescents. This is that kind of contagion factor that we often see, certainly in residential treatment settings and in schools. We do know that LGBTQ plus youth are 4 times more likely to attempt suicide than cisgender or straight youth. I think that an important kind of modifying statistic about that is that when LGBTQ plus youth are in environments where they feel supported by their peers and family members, their rates or risk of suicide matches similar to non-LGBTQ plus youth. So it really is this idea that it's the environmental support factor that seems to mitigate or potentially increase, in many cases, the elevated suicide risk for those youth. Okay, just checking chat real quick. Okay. One of the most important things when we think about working with individuals with suicidality is this. And so I'm going to ask you to just put into chat, and this can just be in the webinar chat. When you're working with an adolescent or a young adult who is experiencing suicidal thoughts and feelings or behaviors, what emotions or reactions come up for you? Hopelessness, panic, fear, worried, empathy, angry, frustration, nerves. I like that. The nerves kind of go on fire. Yeah. Scared, nervous, urgency, yeah. Concern, unheard, feels like a crisis. Yeah. These are the most common. And I think everything that I'm seeing in the chat really is a theme of this, right? This is challenging work. And I have certainly felt all of these. An important consideration is that if we do not manage our own emotional reactions, we run the risk of becoming either under responsive or hyper responsive. Under responsiveness really looks like we can become desensitized to the client's expression of suicidality, and we cannot take the client's pain or risk seriously. So we can minimize it or say, oh, they're just being dramatic again. If we aren't managing our own frustration or sadness or feelings of helplessness. Conversely, we can become hyper responsive, which really looks like becoming over controlling, demanding, hospitalizing, maybe unnecessarily, um, requiring frequent check-ins, or engaging in more can feel like coercive practices. Um, Either the under responsive response or the hyper responsive response can result in undesirable outcomes. Specifically, it may trigger suicidal behavior. And we'll talk more about why when we talk about the suicidal mindset. Um, it certainly might encourage the client to silence their expressions and their thoughts about suicide. If we overreact and quickly hospitalize or become controlling, the client may learn I should never talk about this again because I don't want to, have EMS or the police called. Um, and it may cause damage to the therapeutic alliance, or clients may just withdraw from treatment altogether. One way that's really helped me to manage my own reactions, even though I often still feel all of these when I'm working with individuals with suicidal intensity, is to really understand the suicidal mindset. Suicidality, I like to think of it as a state of being. It's like being depressed or anxious or hungry or in pain, right? Suicidal behaviors alone does not automatically indicate a mental health diagnosis or an emergency. What it indicates is a problem. Suicidal presentation is transdiagnostic, meaning it can show up in any diagnosis, whether that's a psychiatric diagnosis or a medical diagnosis, or it may be present without any diagnosis at all. Suicidal behavior is often comforting or distressing to patients. Um, and sometimes the same person will find both comfort and at times distress from their suicidal behaviors. Suicidal behavior is a solution to a perceived problem. So, a good way to conceptualize it is it really is a coping strategy um, for that individual's pain. There are many amazing theories of suicidal behavior. And when I looked at all of them, these are the main commonalities between them. Suicide really is not about the desire to die, although dying may be the ideal option, but it is mostly about an escape from intolerable pain. And I think we can all relate to that. We all at times want to escape something that's difficult or hard. So for the individual experiencing suicidality, death seems like the only escape option. So it is a solution. It's often related to hopelessness, disconnection. Feeling suicidal certainly impacts an individual's cognitions. They often get what's called cognitive constriction, meaning they can't see the full range of options. Um, and there's usually some type of trigger for suicidal intensity that could be an internal or external trigger. One of my favorite theory of suicidal behavior really is the ideation to action framework. This is out of Thomas Joyner's interpersonal theory of suicide. And I often use this graph and show it to my clients, and we walk through it together. What it's really shown is that what creates suicidal ideation is this idea of pain that could be both physical pain or emotional pain, hopelessness. So that is feeling hopeless that that pain will ever alleviate, and that those two create suicidal ideation. So an example would be the most physical pain I've ever been in my life was I had a very large kidney stone and I thought I was going to die. I actually kind of wanted to die, right? But I knew that I could go to the emergency room, get some IV Toradol, and that it would pass. So I was not hopeless. Although the pain, I'd rather be dead than feel this pain. I wasn't hopeless about it, so I did not experience suicidal ideation. When I think of some of my patients with chronic pain conditions or terminal illnesses or just lives filled with trauma and very little way out, it makes sense that they feel so hopeless that they may experience suicidal ideation. What moves the ideation into suicide attempts are two things. One is this low connectedness to life. This really is feeling like you have a purpose, social connections, and feeling like a burden to others. So when someone is experiencing a high level of pain and they're hopeless and they have very little that's connecting them to life, right? That may increase the suicidal wish. And then capability is probably the most important thing and the thing that we can often mitigate the most in our treatment. And this really is the capacity. Does this individual have the capacity to engage in the level of self directed violence that would be a suicide attempt? So, this really is both access to lethal means, but also dispositional and genetic factors such as pain tolerance, risk taking, impulsivity, life experiences. Um, this is often why non suicidal self injury or self directed violence really is a higher risk factor for suicide attempts. Just pausing to see if there's any questions. Okay. One way that I like to think about this when I'm talking with my clients is really this idea of, does their pain exceed their connectedness? So when I work with maybe young adults who are parents, right? Um, they often have intense amount of pain, feel very hopeless about their situations, but they're extremely connected to their children, right? And so that may help prevent a suicide attempt. Another way to look at the suicidal belief system, this is from Thomas Joyner and David Rudd, which is really research shows that individuals who experience high levels of suicidality really have this pervasive hopelessness. They often also have core beliefs that they do not deserve to live. So, unlovability. They also feel extremely helpless, like they can't solve their problems. So, very ineffective. And they often have poor distress tolerance in their ability to stand this pain. The purpose and function of the suicidal wish, we've kind of talked about some of it here. Um, but often it is really a strategy to obtain nurturance and connection. So we think about that disconnection, the suicidal wish may actually increase connection. And this is where we think of this attention seeking. So, going back to the comment about an individual who works on an ACT team, and most clients have BPD, which is attention seeking behaviors, right? And it's hard to address. Do we take them seriously all the time? Um, or do we alter our responses? To individuals who have consistent reports of suicidal ideations attempt. I think it's a challenging thing to think about, and I hope to share with you some strategies. Um, One way that I reconceptualize it is that this idea of a bid for connection or attention seeking often is seen as very negative in mental health, right? We think of them as attention seeking or dramatic, and it very much feels that way. So I have that same reaction when I have a client who's intensely suicidal every week. Um, I like to reconceptualize that. I don't think that they are actually attention seeking. I actually believe that they require more attention and they just lack the coping strategies and interpersonal effectiveness skills to meet their needs in more pro-social ways. This cry for attention does not lessen the suicidal risk nor the client distress. So I think it's really in thinking about what what can we do differently to meet their attention or connection needs, right? Because they're continuing to attempt to get attention, if that makes sense. And we will talk about treatment plans. And yes, you should always add suicide to any treatment plan. So, the purpose and function of the suicidal wish or having suicidal thoughts also is a symptom and pain relief. So experiencing suicidal thoughts or even making plans can actually decrease an individual's pain. And when we think about this, this makes logical sense, right? I imagine all of us have escape fantasies. Mine is to go sell necklaces on the beach in Mexico. And when I'm having an especially stressful day, I think about I could just go and move to Mexico and sell necklaces on the beach, right? And that makes me feel better. I have actually no intention of doing that, but knowing I have that option, that there is a way out, helps me feel better. And that is often the same for clients with suicidal behaviors. They really feel better. Similarly to my escape to Mexico fantasy, it gives me a sense of control. So when we think about adolescents and young adults who often feel a lack of control in their lives, dying is the ultimate control. So it really helps them feel more in control, right? And that makes sense. It's also a way to manage this deep held belief that they don't belong and they're unworthy to belong, right? Um, so yeah, so I think it's really that's the function of suicidal wish is actually to make people feel better, right? And so how can we help them feel better differently? And I think that really creates the biggest dilemma with suicide for us as providers. And I would say the conflict. So I have two um, deer here fighting, right? Because this really is the biggest problem. Our emotional reactions and our biases and values really impact this dilemma. As therapists, our goal is to prevent suicide. Makes sense. We're ethically, if we're working our organization, we're ethically and legally mandated to prevent suicide. However, our client's goal is to eliminate pain and suffering via suicidal behavior. And what do we know when the client's goal and the therapist's goal do not align? Treatment generally isn't very successful, right? If we are operating with different treatment goals, treatment's not going to work very well. So I want to challenge all of you to change the goal. And remember that ambivalence is always present for any person with suicidal behavior. If they weren't ambivalent, they wouldn't be seeking treatment. They wouldn't be talking to you. So that ambivalence about I want to live, I want to die is always there. So we have time to change the goal. And instead of fighting with our clients about this life and death struggle, we could actually collaboratively set a goal with the client to decrease suffering. And what that really looks like is we focus on improving life, not preventing death. I think we have time. I'm going to show a brief video with our best therapeutic tool to help clients with suicidal behaviors.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Hi. And yes, I saw in the chat that was Brene Brown talking about empathy. So when we think about empathy, one of our best suicide prevention tools really is to empathize with the suicidal wish. And if you're working in this field, it's likely that you are already an expert in empathy. We are so good at providing empathy to our clients who are in pain. However, when it comes to the suicidal wish, clinicians often miss the mark, including myself early on in my career. Probably because the stakes feel so high, right? Both the patient and the therapist feel scary, angry, worried, vulnerable, and we move away from what we know helps. What the research really shows, um, there was a group of suicidologists, and they did a tremendous amount of research with individuals who had attempted suicide or had intense suicidality. And they asked them what would have helped in that suicidal crisis. What would have helped you the most? Here's what they overwhelmingly said. We could have only talked to a person when they were in that suicidal crisis who we knew would not be afraid of listening without judging. In a suicidal crisis, we could never have trusted a person who would want to talk us out of it. When can actually be empathetic with the suicidal wish, which really means assuming the suicidal person's perspective and seeing how this person has reached a dead end without trying to interfere, stop, or correct the suicidal wish. We really attempt to empathize with the patient's pain to such a point that we can see why suicide is the only available option to the patient. This is hard to do. It often feels like a betrayal because it shines the light on all of our worst fears. But when we can resist the urge to move too quickly into assessment and safety planning and problem solving, or trying to make clients feel better, we actually can have much better results. And so here's kind of how it works. We just sit and honor the patient's emotion. We manage our own beliefs. We want to remain very neutral. And we really seek to understand and move into curiosity. And that's often by asking really difficult questions. Why do you want to die? Right? Why? What do you hope for? What do you think will happen after you die? And we want to avoid fixing, problem solving, or providing comfort. Because for a suicidal individual, when they're in that level of pain, solutions and comfort giving often feel more disconnecting, right? Just like if connection is one of the things that keeps people from attempting suicide, we want to do everything in our power to increase connection. And that's really not working against the suicidal stream. Clinicians often feel that if they empathize with the suicidal wish, then they're communicating acceptance of suicidal behavior. However, the opposite happens. As the patient begins to understand their own pain and feels understood by us, then the pain begins to dissipate. and the patient becomes open to other possibilities. Until we can empathize, we, the clinician and the therapist, or the parent and the child, are really locked into a life and death struggle that we have no control over. Joel Paris says the most empathetic position for therapists to take is to let the patient know that although we disagree that suicide is necessary, we understand that for the present, it needs to be retained as an option. There are lots of benefits to when we can empathize with the suicidal wish, and they really relate directly back to that suicidal mindset. We actually teach clients to tolerate their pain, which is what we want them to do, right? We can't, they have this tremendous amount of pain and we can't solve it right away. So we want clients to be able to tolerate it. Just like me, I had to tolerate my kidney stone, right, to survive that. And if we are unable to tolerate their pain or to sit with them in the intensity of their suicidal experiences, we're actually communicating, yep, your pain is too intolerable, right? Which may increase suicidal intensity. We also demonstrate to clients that treatment and process is more important than action, which is exactly what we want a person in a suicidal crisis to do, is to slow down and to sit with it and process what's going on. That's the function of a safety plan, right? And so if we move too quickly into action, we're actually communicating, yep, your pain is so severe, we have to act. And that may communicate to the client, you need to act, and their action may be a suicide attempt. We communicate our understanding of their pain and suffering, so they'll feel more understood, which increases connection. We increase their exploration of self, can be a corrective emotional experience. And I think most importantly, we support the client's active self-healing, meaning it can increase their sense of self-efficacy. And here's just some helpful ways that you can empathize. I want to move into risk assessments. And I'm seeing some comments in the Q&A, and we will get there. We will talk about children and parents. We think about what the purpose of a suicide risk assessment is. Maybe just put into chat. What do you all think of when you think of a suicide risk assessment? Oh, yeah. As I'm waiting for responses, I see comments about empathy. They relax and open up 100%. Okay, so assessing passive versus active suicidal, determining severity, the likelihood, means, method, opportunity, imminent danger, level of risk. Yep. All of those things. So I'm going to challenge us to maybe think a little bit differently about suicide risk assessments. All of those are important, 100%. But this is what we typically think about when we think of a suicide risk assessment. So we have someone who's in the top of that building and he says, I'm going to jump, right? Our initial risk assessment is this person going to jump? The answer is probably yes. So I would immediately panic and say, don't jump, right? Let's call EMS. Let's get out there. Which makes sense. But the actual purpose of risk assessment, in my mind, and what the research shows, is to zoom out. When we look at the picture now, when we zoom out and look at the bigger context, this changes our response. Now I'm probably saying jump. We've got the fire department down there. They might have a blow up thing, right? I'm saying get out of there. You probably should jump. The purpose of risk assessment, in my mind, is to understand why. Why do you want to jump? And until we understand why, we will not know what treatment intervention or what action we and the client should take. When it comes to the standardized risk assessment, Stacy Friedenthal says, just look at it. It can seem like an interrogation because it's just question after question we're asking for our own benefit. I have yet to hear a patient say, I just knew when I woke up this morning, I'd feel much better when I was asked 15 yes or no questions about my suicidal thoughts. Those questions are for us. So I want us to get really clear. The standardized suicide risk assessments were built for us. A patient who's struggling with suicidal thoughts has very different needs from ours. Sometimes patients will tell me, I need help staying safe. But most of the time, they say, I need to feel better. I need to stop hurting. The one size fits all approach to suicide risk assessments actually can distance and marginalize suicidal patients, and, in my opinion, contributes to the lack of effectiveness in mental health professionals and creates a sense of distrust. So I'm thinking to the previous comment of the ACT team or individuals with more chronic or persistent suicidal ideation, right? It creates a sense of power imbalance where it really places us as the expert, leaving little room for clients to establish their lost sense of self. And I'm not against the standardized. I use the Columbia in the clinic that I run. I think they actually are helpful and are needed. But I think we can have a very different approach when we use them that will make us more successful and it will make it better for the client. It's also really important to recognize what suicide risk assessments are not. Although they are a requirement and we need to do them, they actually are not at all predictive. They do not tell us who will or will not die by suicide or attempt suicide. They may place people in higher risk categories, right? So they can give us information about risk and what interventions we need to do. But our current risk assessments, Dr. David Jobs and others, it's no better than flipping a coin as far as who will or will not die by suicide. Um, they also are not generally unreliable, and they are not protective for clinicians in the way that we think that they are. And in most cases, they aren't at all helpful for clients and they aren't therapeutic. So I think we need to shift our focus of what the goals of suicide risk assessments can be, and that will help us have them be more meaningful. In my mind, the goal of suicide risk assessments really is to understand the individual's suicidal belief system to build a therapeutic alliance. We really want to create safety for the client within the relationship. And it really is to get to crisis safety planning and to identify treatment goals and interventions. That's the most important thing. So when we can view clients as co-evaluators or co-participants in the process, and create a normalizing frame for their experience, you can actually use a standardized risk assessment and have it be much more meaningful. A good way to do that, whatever assessment you use, whether that's the Columbia one that your organization created, the ASQ, doesn't matter. I always start every suicide risk assessment with the narrative approach, which is really, I just ask the client to tell me their story of their suicide attempt that impacted them the most, their suicidal ideations, if they only have ideations, the most recent, the most potentially lethal. While their narrative continues, I just empathize and I resist moving into crisis or problem solving mode. That is where you will actually gather the most information, when you are just not focusing on silver lining it, as Brene Brown would say, or trying to solve their problems, but you're just listening and gathering. We also want to become really curious about suicidal ideations, frequency, triggers, intensity. And I think the Columbia actually does a really good job of this if we can use the Columbia in a very narrative, collaborative way. And then another way to think about it is to recognize that suicidal thoughts are often comforting and provide relief. Um, and so asking about what problem might the suicidal behaviors be a solution for, right? And then normalize the experience for the client. The main domains we want to assess for in suicide risk, and I would say doing this with every client at intake or any changing condition, are really the baseline risk factors. What events activate suicidal behaviors? They're different for everyone. Current symptoms, belief systems, impulse control, and behavioral dysregulation. That really gets at that capability or capacity, and protective factors. Also, really important to evaluate both client report, self report, and behaviors or functioning level. Clients often overestimate or underestimate their psychological symptoms. Even though most suicide risk assessments use categorical risk levels, low, medium, high, for many individuals, especially adolescents, who it fluctuates so often, or maybe they've had 3 suicide attempts, so they're always in the high risk category, right? I think in comparison states, um, I compare the client's risk to themselves, maybe their baseline, their last session, their last suicide attempt. And I actually encourage clients to begin to self assess and self monitor their suicidality. Um, and that I think really all leads us to safety planning. Safety plans really are meant to aid in the management of suicidal crisis. So when we have done a comprehensive narrative, or standardized suicide risk assessments, we should be able to have a really detailed information to co-create a safety plan with the client. Um, and really, the goal of the safety plan is to overtly negotiate with the patient to put off suicide to a later point in time, right? So it's meant in that suicidal crisis, let's wait till tomorrow and see if things get better, right? Because most of the time it will. Um, Safety plannings have been shown to be highly effective when they're used well, and constructed well, being very individualized with clients. It's been shown to have an immediate improvement in the client's emotional state. So, in the beginnings of that suicidal crisis, if the client can remember or see their safety plan and begin to use it, they actually immediately start to feel better, which makes sense when we think about the suicidal belief system, right? If they feel helpless and they use their safety plan, they're actually gaining a sense of self efficacy, which may challenge that suicidal desire. It reduces suicide attempts, and there's a quicker resolution of a suicidal crisis. Also, a reasonable safety plan is an alternative to hospitalization always. And we'll talk more about hospitalization. What I like about safety planning is being pretty creative with them. And I think we have to be. There's many different, most organizations have a standardized safety plan, but it really should be a collaborative process. The goal is not to control. Um, it may require a tremendous amount of patience on our part and on the clients because they can be hard to construct initially. And we want to update them constantly. It's never a one and done. Oftentimes with safety planning, um, we have to really think about what's working for the client now, right? Many times what's keeping them alive is the fantasy of suicide, right? So one way to conceptualize suicidal thinking is it's the get out of jail free card, right? It allows the person to live and keep on struggling, right? Um, and that's very hard to think about. That's something that is so final. Um, but we need to plan around that and recognize that suicide may still be on the table. And for most individuals, suicide is always still on the table. But we can find out what else works: harm reduction, emotional regulation, humor, spirituality, and get really creative. Um, and alternatives to social supports and connection. This is often really challenging when working with safety planning with adolescents, maybe who are really isolated. So I often think about what alternatives to human connection could be made: pets, hobbies, nature, peer support, all of those things. It can't, many people do not have a person that they can call or a friend. So, what else could provide some type of connection in their life? When we think about means restriction, which really is probably our most successful tool to prevent suicide death, um, we want to ask often about other plans. From my experience, if an adolescent has thought of one suicide method, they've thought of more than one. So, whenever someone discloses a suicide plan or means of suicide, I always ask, what other ways have you thought about that? Um, but we can get really creative with lethal means restriction. And the goal really is to decrease capability and involve the patient on what they think will work best. We always want to involve family and support systems if the patient consents, if they're an adult, and certainly with adolescents, depending on the state and what the laws are related to age of consent. Um, and I think this can be a challenging process. My preference is always to remove all lethal means, and that may not be feasible for many patients. For example, I have a patient who has chronic pain and also has a, suicide method or plans to overdose on their pain medication, right? They live alone. They don't have access to, don't feel safe handing over their prescription opiates to a family member or friend, which I get, those are expensive. So, how do we mitigate, right? Removing the opiates from the home is not an option. Not having the opiates is not an option. Sometimes blister packs or 1 week doses of medication can be good. That can also be more expensive for patients. And for this patient specifically, she just has a lockbox where the majority of her opiates are kept. And then she has a weekly pill minder where she keeps her daily. Now, if she were in a suicidal crisis, she could very easily go get into her lockbox and find all the medications, but it would delay that time. And in those suicidal crises, that short delay can be really important. The other important thing when it comes to lethal means restriction is that in most cases, individuals do not jump from one means to another. What that means, if I'm working with an adolescent who has a suicide plan or fantasy to use a specific knife to slit their wrists, if I can work with them to remove that one knife, it is unlikely but not impossible. But it'd be much less likely that they would go to the kitchen and grab a knife at random. So people typically have for hanging a specific belt or something that would be important in their suicidal fantasy. That makes sense. There are many different safety plans. Often they're the Stanley Brown, modeled on the Stanley Brown plan. My favorite safety plan is contingency specific safety planning, which really says when you've done the suicide risk assessment, you should know what the potential triggers are. What things for that person really increases suicidal intensity, right? Um, for many individuals, it is interpersonal problems. My dad yells at me, increases suicidal intensity, or being bullied at school, right? So the idea of contingency specific safety planning is planning for those triggers that may happen. So if your dad yells at you, here's what you're going to do. If my boyfriend breaks up with me, here's what I'm going to do, right? And I think that can be really powerful in both the therapist and the client being able to plan for what may happen. But then also they know exactly, they've practiced, they know what to do if that event happens. Um, and then all the other safety plan elements are included. The other really important thing is I always recommend multiple safety plans for multiple settings. So thinking about if you're just doing one global safety plan, right? And you're working with an adolescent and their number one thing to do on their list is to call their aunt, right? You need a different safety plan for when it's 2 a.m. because they may not be able to call their aunt at 2 a.m. Maybe they can, but maybe not, right? Or they may not have access to their cell phone. Maybe there's rules in the home. Same with you need a separate safety plan if you're in residential treatment versus at home with parents, or if you're at work, you need a different safety plan than you're when at home. And so I think really in working with my clients, I encourage multiple safety plans for different settings. The other really important thing is to actually practice using safety plans when you aren't in crisis. When we think of preparing for something really difficult, like a boxing match, we have to train and practice. When I was doing substance abuse with clients, I would develop relapse prevention plans with them, and they would create some beautiful relapse prevention plans if they had intense cravings, like go to the gym, call my sister, watch my favorite movie. They sounded great. But then I'd ask them, do you have a gym pass? No. How often do you call your sister? On her birthday and on Christmas? Do you own your favorite movie? No. Those plans aren't going to work, right? Because you can't put something on a plan that you don't regularly do or that's not becoming a habit, right? Especially not in a crisis. If you never call your sister in a crisis, you're much less likely to call your sister, right? So safety plans when it comes to suicide are similar. I think of I describe it to clients as a fire alarm, right? We do fire alarm drills in school or at work. So when there isn't a fire, so if the fire happens, we know what to do. So one of my first homework assignments after doing a safety plan really is to help clients practice them. When they can practice their safety plans and their coping strategies when they aren't in crisis, it really allows us and them to evaluate, will this be an effective tool in a suicidal crisis? I mentioned before, but the crisis response plan or safety plan is a living document like a suicide risk assessment. It is always being updated. So We want to reevaluate, update constantly, and practice constantly. Every session, especially working with an individual who's experiencing suicidal behaviors, I ask about the use of their safety plan, what helped, what was not helpful, and what do we need to change. It's also really important to ask clients how likely they are to use their plan. I'm always surprised when I do safety plans with clients and then I ask, how likely are you to use this or how effective do you think it will be? That they will say, not at all, right? Because they're doing it more for us than for them. So I think it's this idea of this co collaboration. Okay. Getting to the questions about collaborative safety planning with caregivers and or support systems, right? Um, so I do think that even with adults, if I can do a collaborative safety plan, usually initially with the adult, but then I want to involve other supports with consent. Um, Sometimes that can look like supervision and monitoring by parents or caregivers, right? But it can be a really impactful process. There was a question about um, a client who is a child and that who had a parent who attempted suicide in front of the client in the past, and they're afraid it will happen again. And how can we use that to help our client plan a safety plan? How do we appropriately help the parent with safety plan, or can we not because the parent is not our client and the suicidal thoughts are not active? That's a difficult question, and I think it's a challenging one, right? And very often when I'm working with adolescents and or children with suicidal behaviors, they often have suicidal intensity in their family systems, right? Whether it's an older brother or a parent. So it's not uncommon. Um, and I think it really is this collaborative safety planning process, right? And I often create two safety plans, especially if I'm working with adolescents. I'm creating two safety plans, one for the adolescent client and one for the support system. I've even done this with young adults, where in the plan, um, the adult client is completing one and the spouse is completing a safety plan, right? And I think that makes sense because if you're supporting someone who experiences suicidal intensity or mental health challenges, that person also likely needs support. And it becomes really powerful actually for adolescents and young adults who may be struggling with their sense of autonomy to say, okay, mom, dad, spouse, you need to do a safety plan now too, right? It helps normalize things. So I found really big success. So in my mind, I probably would use two safety plans with that youth and their parent. Because I think we could all benefit. I have a safety plan for me in working with highly suicidal individuals. I need my own safety plan. I would so I think that's important. When we're thinking about working with parents and support systems, it is a shared responsibility because we really need them often, especially when it comes to making the environment safe and providing support. So I think it can be really important and impactful. When we think about tips for conducting support sessions, and this is the same for adults and for adolescents. We want to really establish clear expectations and goals with everyone. At times, it may be family therapy. In most cases, it's focusing more on safety planning or gathering more information from for the suicide risk assessment. I'm often providing a lot of psychoeducation about suicidal wishes, the function of suicidality, um, and at times I have to be more directive. So I prepare clients for this. I work pretty closely both with adolescents and with adults to identify any preferred off limit subjects, right? What do you not want brought up? And any possible triggers that may occur during the session. Um, again, so that we can plan around that. At times, I've created a safety word with the client that may indicate, hey, we're going to end the session now or take a break. And I always check in with my client directly following the session. Often, I actually have clients lead the support sessions themselves, even adolescent clients. And I have found that to be tremendously impactful um, for adolescents and young adults to have it's their life, it's their safety plan. Let's put them in charge of it, is my thought. And I'm there to support. Um, and it gives them a greater sense of self efficacy. We'll look at I'm thinking about, I guess, any questions about what we've been talking about so far? I just want to pause for a moment because I feel like I've shared quite a bit and have talked a lot. I see the question about hospitalization, and we will get there. Huh. I mentioned this briefly, but if you're working with family systems or support systems in general, they often need their own support. So I'm often recommending support or treatment for family members who have a loved one who's experiencing suicidality. I have them do a crisis safety plan, like I mentioned, and I provide a lot of psychoeducation. And I do recommend reading, and I have some recommendations in the handout about that. Oh, mm, yes. So I'll go back to the contingency based. So it really looks like we're talking about how I have them do the exact same plan that the client's doing, but it's for them. So they're identifying what are my warning signs. Maybe it's not for when I'm becoming suicidal, but if I'm working with a parent, maybe it's when I'm getting overwhelmed, when I get frustrated. What are my warning signs? What can I do to cope? The potential trigger may be my child expresses suicidal thoughts. What am I going to do? Right. Um, so I have them fill out their own crisis safety plan just like the clients. Um, and it is super effective and fun. And what it actually happens is it helps normalize, especially I would say for adolescents and young adults where they feel so pathologized, right? That they're the problem. And so when you're doing it jointly, I used to do it in inpatient all the time and the adolescent says, well, mom, when you do this, I know you're upset, right? So it really helps normalize and creates this beautiful connection in that, hey, we both struggle, right? Maybe in different ways. So it's really powerful. Um, yeah, I hope that that answered your question, but I treat it just the same where we're doing it together. Um, and sometimes I may need to meet one-on-one with parents, or they ask to meet one-on-one later because they're also struggling with suicidal thoughts. And then I may help them connect them to their own treatment or do a more specific suicide safety plan for them. That happens sometimes. Yeah, please let me or Jackie know if that did not answer your question. Okay. I want to We're doing pretty good on time, so we definitely have more time for questions. We will be able to get through everything. But I wanted to shift gears a little bit in thinking about moving through treatment. Um, we talked about empathy, and I think that is foundational throughout treatment. We talked about suicide risk assessments and how you can approach that from a more narrative perspective. And the goal really is to understand the why, zoom out and get the context, and then the development of crisis safety plans and how we can be much more creative and adaptive with those plans. And then once we have established that a person is experiencing suicidal intensity and they may be at risk of attempting suicide, then we actually have to provide some treatment. And it's really important to remember that any expression of suicidality requires suicide focused treatment. What that means is if you are working with an adolescent with major depressive disorder and PTSD, um, and you only treat the depression and PTSD, suicidal thoughts do not improve. Depression will get better. The PTSD will improve, but suicidal thoughts from the research do not improve without suicide specific treatment. Um, And that, I think, has been one of the reasons why our field has struggled with managing because we think they're suicidal because they're depressed. So if we just treat the depression, suicidal thinking will go away. That happens sometimes, but from my experience, the suicidality mostly persists. Um, and that's really what the research shows. Suicide focused treatments, which as far as evidence-based, right, are DBT, CAMS, the collaborative and assessing management of suicide, Dr. David Jobs, cognitive behavioral therapy for suicide, brief cognitive behavioral therapy for suicide, mentalization, and many others do have some evidence that focus on that improve suicide attempts. There's actually not much evidence right now that suicide-focused treatments decrease suicidal thoughts. Part of that could be the research, the way that the research studies are done, that they're mostly looking at attempts. But the few research studies that have focused on suicidal ideation have shown that there's little movement in decreasing suicidal ideation, but certainly in decreasing attempts. So I think this really is key that we need to engage in more focused suicide specific treatment, which would including suicide on every treatment plan or at least one treatment plan. When we think of the foundational practices of suicide focused treatment, it really is focused on the therapeutic relationship, which makes sense. When we think of suicide as a very disconnecting experience, right? And that lack of connection, it is our ability to maintain a relationship that becomes the primary factor. Our ability to empathize with the suicidal wish and manage our own emotions is key in this process. The goals of treatment, from my mind, are to resolve the immediate crisis. So if this is an acute situation of suicidality, we want to resolve that crisis. Reduce suicidality by diffusing or delaying suicidal thoughts and behaviors. I often think of this as externalizing, right? Helping people to recognize a separation between having a suicidal thought and that they are always suicidal. We want to increase hopefulness, right, in the immediate future. And really, that's done by increasing hopefulness that treatment might work, right? We think of that original three-step theory, it's pain plus hopelessness that creates the ideation. So, our first clinical intervention really is to create some buy in that treatment might work in improving their pain, right? And then we want to reduce symptomatology. What does the client need now to feel better? We want to lean into strengths. So helpful treatment, we want to lean into strengths without calling them strengths. Um, and that's often tricky, right? But important. Often, especially individuals with high levels of suicidality or emotional dysregulation really resist comfort giving. So I often think of it as the client's pain is just greater than their skill level right now. Distraction skills work great, mindfulness, and some of those core DBT skills can be really helpful no matter what your treatment, theoretical treatment model is. When we think of symptom management or my goals of treatment, it really is to help clients assess and understand their own suicidality, right? Evaluating what skills they're currently using and do they want to change them, right? This often becomes challenging because many times my clients will say interesting things. Um, like my skill tonight to feel better is to plan my funeral. Now, that is not a coping strategy that I would pick for them, but they don't want to change that, and it's actually helping them. So I need to understand what the purpose of their current coping strategies or just stress tolerance skills are, and do they want to change them? Um, and it really is focusing on this idea of teaching them to understand themselves. And that includes exploration of common themes, what warning signs may trigger. Um, yeah. And I think it's an interesting kind of paradox, and I liken it a lot to working with individuals with substance use, right? Or thinking of harm reduction, in that we have to understand why they use substances and how that may have been helpful for him. Um, yeah. Guess the other thing I'll say about that really is my goal, and I share this with clients, and I've heard this said similarly by Craig Bryan or David Jokes, is the goal is to help the client become their own suicidologist. Mm. And when they can understand themselves in that way, then they often feel like they have more of a choice. I also think when we think about treating suicidal behaviors, it can't just be about suicide. And new clinicians often resist delving into other painful therapeutic topics due to fear of increasing suicidality. But if we think back to our original dilemma, right, our goal, we can either have a goal to prevent death or to improve suffering. Um, and hopefully we want to do both, but our primary goal should be to decrease suffering because that's the client's goal. And that can't happen unless the source of the client's pain and isolation is addressed and treated. So this occurs after and simultaneously with managing the suicidality. It really teaches clients and us to tolerate emotions, um, and identify um, how they can help, right? So I am doing active trauma treatment and other types of, symptom management treatment alongside suicide focused treatment. Because I really feel like if I don't address the person's not going to not be suicidal until their PTSD is addressed, for example. Um, One thing is to really always targeting pain and sleep disruptions, sleep insomnia or poor sleep is there's a high correlate between sleep and suicide attempts, impulsivity, right? So working on all of these areas and co-treating them becomes really, really important. And I would say it's a delicate balance. So one thing I'll say is most of my adolescent clients have high levels of suicidality. And so we're often doing a little bit of trauma focused CBT, for example, and then addressing their increase in suicidality for a few weeks and then returning. Um, Similar with substance use or anger or other, you know, they are struggling with psychosis, for example. Then we're kind of co-managing both problems, but really thinking of suicide as a separate and distinct clinical issue becomes really important. Mm. Yeah, so there's a question about why some clinicians are reluctant to treat those with suicidality. Um, I don't know if I can say why. I think a lot of times it's because it feels so overwhelming. Um, so I was certainly one of those at the beginning of my career, um, where I didn't want to treat suicidality. And I think it was the fear of I have no control, right? And suicide, um, certainly is there's a tremendous amount of professional stigma and judgment when it comes to suicide or losing a client to suicide. So I would say I think that's often the fear of litigation or malpractice um, really isn't that much higher than any other disorder, but it creates more fear for us. And I also think that many clinicians don't have a good understanding or aren't well trained in managing suicide. At least I wasn't. Um, and that creates fear because we don't know how to address or treat suicide. Yep. Yeah, and I will just validate, it is terrifying, the auditing, that may happen after a client dies by suicide. Um, yeah, so I think that's often why, and for me, um, my hope is and why I present is to maybe say, my guess is we are all treating clients with suicide, we just don't know it. And that's been really my experience as I've worked with clients. Now, in my small private practice, they will come to me and say, I've been in therapy for 20 years. And I told my therapist about my suicidality, and then we never talked about it again. So they were in treatment, actively suicidal for 15 years and never talked about it. And that is not uncommon because clients really learn pretty quickly not to talk about suicide because of fear of going to the hospital or being not heard or brushed over. Um, so my guess is most of us are working with clients who experience suicidality, even if we don't know it. Oh, if parents are resistant to safety planning themselves, I just have a conversation. I'm often giving direct feedback and saying, hey, let's get on the same page. Your goal is to keep your kid alive. This will help them. Most parents, when you frame it that way, they are going to say, okay, I'll do it. I'll do what I need to. Not all. And if they're resistant, then they're resistant. So I think you just have to roll with it. But most parents I have found are not resistant to safety planning and kind of find it fun. In every session, when we think about suicidality, in every session, we want to attend to the therapeutic relationship. We want to assess any changes in the intensity of suicidal risk. Um, and I think that's really key so that we're at least talking about suicide every session. We want to review and update the crisis response plan and address any lethal means if needed. I always assess connectedness, daily functioning, changes in ambivalence, and I work on skill building, especially when someone's in a more acute suicidal state. I would also say, maybe a reminder, that if you're working with someone with any level of suicidality, it's really important to have a suicide specific treatment plan. And my treatment plans, in most cases, are not an elimination of suicidal thoughts because that is often unrealistic. Um, it's really, can they manage their suicidal thoughts, right? Can they learn skills? A treatment plan goal might look like successful use of safety plan, right? Or using safety plan once a week, even when not in crisis. And I think that that becomes really key, that we're focusing on what the client will actually do versus what they will not do, if that makes sense. Um, Focusing on what clients will not do is often a recipe for um, less success, I would say. Thinking of, if you're working with a client who maybe has a lot of punitiveness or negative self talk, um, you can give the kind of treatment homework or your monitoring assessment to say, I want you to document every time you have a negative self thought, right? Which makes sense. But what happens is the clients document, oh, I thought bad about myself. And then they think I punitiveness actually increases, right? Because they're like, felt bad. I talked bad to myself 5 times, and then I'm feeling bad about that, right? A more effective strategy is saying what they will do, which is document how many times you have a positive or a self compassionate thought. And I think the same applies for suicide, right? Instead of saying how many times you have this thought, the suicidal ideation, right? Which is what we don't want to happen. Maybe it's flipping it and saying, when you do, were you able to manage it within 10 minutes, right? Were you able to effectively use coping strategies? And that's a much more effective treatment plan and increases self efficacy and compassion for clients. One thing I wanted to say was just kind of some special implications or considerations, especially surrounding ADHD. And I would say this applies for both young adults and adolescents. Individuals with ADHD do have an increased risk of suicide attempts, not necessarily suicidality themselves. Um, and I think that oh, and I just realized there's a ton of questions, so I will leave some time at the end and we will get to all of those. Um, it's really this impulsivity. So the more work we can do with clients on managing impulsivity, that really can help prevent, and using good safety plans can help prevent suicide attempts. Um, im- Implications for clinical practice when working with suicidal individuals, the importance of interdisciplinary teams, and I would say if you're in private practice, consultation. I don't think anyone can work with individuals experiencing suicidality without in a vacuum. I have to have support to do this work. I need to be able to consult. Um, Often, at times, intensity of treatment may need to be increased during especially stressful times. Um, we have to be willing to dig into the client's pain experience and their trauma. Um, and I think really, I like the idea of externalization. I talked about that. And we have to be willing to at least embrace that the option of suicide might be what helps our client to stay alive right now, right? And that we can't control. We have to embrace our lack of control. Um, and that's really a hard thing to do because we'd like to think that we can control and know and predict suicide, but we can't. And if we're holding on to that too tightly, that really can impact our clinical work. Um, at times, we may need to extend boundaries as clinically appropriate. Um, that may be scheduling more frequent sessions or whatever your emergency availability in a suicidal crisis is at your clinic. Um, but I think we also need to ensure that we aren't creating dependency or reinforcing the patient's belief of helplessness, right? So, depending on your theoretical orientation and the setting in which you work, both of those could be helpful, both extending boundaries a little bit or maintaining the therapeutic frame. Okay. I want to answer some questions and then we'll talk about hospitalization. And then we will get into it. I'm so sorry I missed the questions, Jackie. Um, so one question was, what are some examples of things you should never say to a client with suicide in the moment? Hmm. I think that's hard to say without each person is so individual. Um, but I think the general one is any platitude, anything that says anything that could communicate your pain is not serious is my general. So that may be like it will get better, right? That may be um things aren't as bad as they seem, right? If someone's to the point of feeling actively suicidal, things actually are as bad as they seem for them, right? So I think anything that would be a pain minimizer or shame inducer. Um, and like I said, each person's different and it really depends on your therapeutic alliance with that person. With some of my clients, I can be much more direct in that way because we've built a good alliance. If I'm meeting someone for the first time, I am just responding very empathetically. Um, Psychological autopsy data as a source for identifying suicide risk factors. That has been the primary source for identifying risk factors is really, um, using decedent data. And there's some concerns with that have been in meta-analysis that have been looked at, but I think that's one reason why suicide risk factors are important to know and much less helpful in identifying who will or will not die by suicide. Mm. Oh, someone's just talking about feeling undertrained as a school counselor and the lack of funding for suicide prevention. And that just I feel you, and it is really, really hard. I would recommend in your state often, then um, American Foundation for Suicide Prevention has some really good trainings that are free. And Suicide in Schools has some excellent free trainings related to suicide, especially for school counselors. And I have some resources on the handout that talk about that as well. Oh, specific emotional regulation tools in treatment and planning. I would say it's so client specific. I usually find out what they're doing to cope now. So if I'm working with someone who is in pain and experiences suicidality, they're already using coping skills to manage because they're still alive, right? Um, and I think that so whatever they're using now, can I adapt it to maybe be more pro-social? I have found in general distractedness, sensory things that help them get out of their mind or out of their body, um, and that can increase cognitive or change the affect in some way to be the most helpful. So I like the DBT skills, but they do not work for everyone. Clients building up distress tolerance. I think it's practicing when you aren't distressed is a good place to start. And we can actually, our response to a client's pain helps them build distress tolerance. So when we can't, if we can sit with a client in their pain and not become distressed ourselves, we actually help the client learn distress tolerance. And I think that's one of the most effective ways. And then helping them practice and find what works for them. For some of my clients, it is breathing through it, it is externalizing it, it is, opposite reaction. Can I think about something positive? It really varies, I would say client by client.
Okay.
Hospitalization, hospitalization is tricky. The majority of suicidologists who were, including myself, who work with this population, recognize that hospitalization, in most cases, is not an effective treatment for suicidality. And I think that that's an important thing to remember. Many clinicians will send, including myself, will send a client to the hospital thinking that that will cure or resolve their suicidal behavior. Hospitalization isn't treatment, it's just stabilization. So, most clients who leave the hospital are still suicidal. They may not be in a suicidal crisis, but they're still experiencing suicidal ideation. There's nothing magical about 5 days in a psychiatric unit that creates someone's pain, does not go away, right? No, it can be very helpful in that they can get an appropriate medication. It can give them a break. So there are some definite pros, but we need to recognize it's not treatment. Um, Hospitalization may increase the risk of death by suicide. That's pretty evident. That's one of the most risky times for clients is within the first 7 to 30 days post hospitalization for dying by suicide. And it may, especially a forced hospitalization, may damage the therapeutic light alliance, and it may actually reinforce to the client that they are not capable of solving their own problems. So it can actually reinforce the suicidal belief system. So when I think of hospitalization um, versus safety planning, my initial thought is always, can I safety plan? Because that will be the most effective outcome for the client. And I think of it just like any treatment intervention. We have to think of side effects, and clinically, we're hoping for positive outcomes, but we need to consider side effects. So when I'm thinking about safety planning versus hospitalization, I think about side effects. And I'm often having this conversation with clients, and with parents if it's a minor, but certainly with clients. So I do a pros and cons list. right? Between hospitalizing versus safety planning. Um, and really, safety planning, what's that impact on self-efficacy, right? If they can get through the suicidal intensity. Um, I always ask the client's perception of risk. It doesn't inform my treatment decision, but I do ask about if they feel like they can keep themselves safe outside of the hospital. Can I decrease or eliminate access to lethal means? Um, and then hospitalization may have a negative impact or may increase feelings of isolation. It certainly may impact financial stress. Um, it can save a person's life and increase the risk of death. Hospitalization can also be really traumatic, and I think that's important to remember. Um, and what is the client's past hospitalization experiences? And I think that that really becomes a key factor in thinking about all of these situations. And each situation is very different, and our relationship with clients and what we know about them. I will say for me, I will not hospitalize any client who doesn't have imminent risk, which I consider to be 24 hours. So if unless I feel like they're going to attempt to end their life within the next 24 to 36 hours, I am not recommending hospitalization because it's not a crisis at that point, in most cases. There are times when I do hospitalize, um, which is rarer and rarer, but when I hospitalize versus safety plan, and the most important thing is to consult. I always am consulting. So I do hospitalize if there is that imminent risk. So if the client says, I don't feel safe, I am going to end my life, or they desire to be hospitalized, I'm not going to prevent someone from hospital. I have no control, just like I have no control over it should they choose to attempt suicide. Um, but if there are, say, I'm going to leave your office, Anna, and end my life, then yes, I'm going to hospitalize. But when I do hospitalize in the presence, there are often secondary symptoms. So if they have psychosis, if they have an acute exacerbation or exacerbation of a psychiatric condition, right? If they're manic, so depressed that they can't move, if they require medical detox, medication side effects, or health problems. So, if they have comorbid symptoms that may exacerbate the suicidal intensity, then I'm absolutely recommending hospitalization and stabilization. Want to ask, I also think it's really important. For some reason, my slide went away, but I have a slide. I utilize the full level of care. So I think in really looking at how can we utilize all levels of care when working with suicidal individuals. So Sandstone mentioned having all levels of care. And if you can get connected with a system, even if you're in outpatient practice, and you're saying that, "Hey, can I send someone to do an IOP group for 3 weeks to help them stabilize?" Right? Or I'm often sending clients to NAMI groups or peer support. How can I increase support in those ways becomes really powerful. Um, in Utah, and I know a lot of other places in the US have the 23-hour crisis models where a client can go into the hospital for up to 23 hours, and that can be really effective in that suicidal crisis and may not require a full hospitalization for individuals. So there's a question about what capacity does the clinician have to provide an intervention to a client's hospitalization? I'm not quite sure what you mean. for preserving the therapeutic alliance? I would say really, for me, I'm always collaborating, and unless there's an immediate reason or safety concern why I cannot, I absolutely am talking to my client and being as transparent as possible. If I feel like they need hospitalization, I'm hoping that they will agree with me and sign themselves involuntarily. At times, I have had to involuntarily hospitalize, and that's often been challenging, and at times clients have said, "I'm never talking to you again after that." And that was a painful process, but can happen. Okay, we've just got a few minutes left. So I wanted to end with a video, which is probably my favorite video, because it gives me hope. And so we'll share that video, and then I'll end with my contact info and any final questions.
I know that you don't want to taste another day, that everything feels cold, grey, decayed. I know that loneliness has moved in and made a home in your heart, that you feel apart, in parts, apart from others, isolated, separate, defected, diseased, defined by dysfunction and constantly teased by the idea that death will appease your pain. But stay another day. I know that you feel broken, as if the parts will never form back together to make a solid, well-formed and functioning heart. But stay another day. Believe that tomorrow possesses the capacity to differ from yesterday. I know that your pain is real, and if I could hold it in my hands, I would feel its weight, shape and form and the heaviness of your despair. But stay another day. I know that depression blinds you, masking, obscuring reality, showing you only what is broken, the shattered glass, sharp pieces, the torn edges, what is dark. Revealing to you only a singular dimension of what it means to be alive, distracting and depriving you from all the reasons that motivate you to survive. Depression blinds and blurs your vision with precision, numbing you to sleep, preventing you from envisioning the future you wish to keep, demanding you accept defeat. But there are so many reasons to stay. Stay another day. Choose to live, choose to fight, choose to stay. Know that what is broken can be mended and sewed back together, repaired, revived, repatched, renewed, restored into something splendid. That the breath in your lungs, the sun on your skin, and the people you love are reason enough to stay. That love drowns out the darkness, silencing the voice of defeat. Conquering deceit, cutting through the misery, it is love that makes us complete. So stay another day, open your eyes and refuse to be blind to the beauty that persists despite the brokenness. Touch, taste, smell and see another day. Because love, joy and hope exist. Please stay another day.
I don't necessarily share that with clients, right? Because it is very hopeful and problem solving. Sometimes I do, when they've progressed in their treatment, but it gives me hope. And I think that's really why I do this work. And I think we also just have to take care of ourselves. And so I definitely encourage that. It's nice to connect with all of you, even in this virtual way, but we really have to, this is hard work. And so I encourage you, reach out to your loved ones, and practice your own self-compassion, and practice in ways that give you hope. Here's my contact info. Feel free to reach out. And the handout also has it. And thank you all so much. And thank you, Deborah and Sandstone. And I'll happily stay on for more questions if there's any.
Thank you, Anna. This was great.
Thank you to everyone. Thank you so much.
Thank you. I'm not seeing any other questions come through. So with that, I think we can end it there. I want to say again, thank you to Anna and Sandstone Just a reminder to everyone, in order to receive your CE certificate, you must complete the post-session evaluation, which will be available within your account within 24 hours after the end of this session. If you dialed into this session using your phone instead of the Zoom app, please reach out to support@tpn.health so we can verify your attendance. And thank you all and enjoy the rest of your day.
Thank
Take
you.
care. Bye-bye.